So systemic lupus erythematosus is just a classic example of any autoimmune disease. Of course, when you hear about the systemic lupus erythematosus, any autoimmune disease, you normally think about systemic lupus erythematosus because the systemic lupus is the classic model of autoimmune disease. So there are different forms of lupus. Not every lupus is a systemic. Not every lupus is systemic. There are other kinds of lupus that are not systemic. For example, we have what we call discoid lupus. So discoid lupus is also what we call cutaneous lupus, and is always limited to the skin and is identified by biopsy of the rash that may appear on the face, neck, and scalp of the head. So discoid lupus does not generally involve in the body's internal organs, but it can also evolve to the systemic form of the disease. So if it is treated, even if it is treated and this cannot be predicted or prevented, so whether we treat, whether we don't treat, it may evolve into the systemic form of the lupus disease. So classic finding in systemic lupus is antinuclear antibody, but antinuclear antibody tests may be negative in discoid lupus. Or sometimes, even if it is positive, it will be at a very low titer. So, but most commonly, discoid lupus has negative test on antinuclear antibody. The second type of lupus is called drug-induced lupus. Drug-induced lupus is also another common lupus associated with some drugs. Those drugs are hydralazine, hydrochloride, and procainamides, hydrochlorides. So some drugs also, example oral contraceptive as well as isoniazid, can also induce antinuclear antibodies without symptoms. So procainamides, which is a classic example of drug which induce lupus, the procainamide induced lupus does not induce antibodies to double-stranded DNA, but of course antinuclear antibodies are particularly antibodies to histones. Even with discontinuation of drugs, antibodies titer usually remains elevated with the for months or even years. So it does not matter. But the antinuclear antibody in the drug lupus is those are antibody against histone, and histone is a protein in the nucleus, right? So even if you have to discontinue the drug, sometimes antibody remain elevated for a long time. So always procainamides can induce a particular type of lupus, which is drug-induced lupus, and the autoantibodies which are produced, those are antinuclear antibody against a part or a protein in the nucleus, which is called histone protein. The third lupus is called neonatal lupus, and neonatal lupus is associated with acquired of maternal autoantibodies. So of course, neonatal lupus, those are acquired maternal autoantibodies, especially of course antibody against Robert. We call them anti-Robert antibodies. Anti-Robert antibodies, those are also autoimmune antibodies. Those are also antinuclear antibodies, anti-Robert and anti-Lane. Anti-Robert is also called, Robert is called soluble substance A, and Lane is called soluble substance B. So anti-Robert and anti-Lane are those autoantibodies that are normally seen in neonatal lupus, and those autoantibodies that can affect the skin, heart, and blood of the fetus and the newborn. So those classic antibodies, two antibodies, anti-Robert and anti-Lane, are both found in neonatal lupus, and they can actually affect skin, heart, and blood of the neonates. So neonatal lupus is associated with the rash that appear within several weeks of life and may persist up to 6 weeks before disappearing. So congenital heart block can also occur, but of course this is less common than the rash. So neonatal lupus is not really systemic lupus, but it can affect different organs, skin, heart, and blood of the neonates. But it is not appearing as a systemic disease. So you need to remember the autoantibodies. That is always what I advise you when you are talking about a certain autoimmune disease. You must remember which antibodies are evolving. If this systemic disease is associated with the anti-nuclear antibodies, you should also understand it. Or if not, then which autoantibodies are then seen, because not every autoantibody is anti-nuclear antibody. Others can be antibodies against other parts, like cytoplasmic membrane, like other cytoplasmic components, and even other tissue components like anti-smooth muscle. It can be another autoantibody, which is seen, of course, in acute autoimmune hepatitis. So systemic lupus erythematosus is, of course, a classic disease which is, of course, autoimmune disease. So systemic lupus erythematosus, it is usually more severe than discoid lupus, even though, of course, you remember that discoid lupus can also progress into systemic lupus. So systemic lupus erythematosus is a multisystem autoimmune disorder. It's a multiple system, or it can affect so many systems in our body, and this can affect skin, joints, and almost any organ in the body, including lungs, right? Including lungs can also be affected, and kidneys, heart, and brain. So systemic lupus may include periods in which few or if any symptoms are evident. So that's what we call remission period of systemic lupus. Sometimes patients are without symptoms, but other times patients actually become very sick. That's what we call fail in case of more active condition of the systemic lupus. So the cause of systemic lupus is not clear, and no single causative agent has been identified so far. But of course, systemic lupus is associated with the primary defects in regulation of the immune system. So that is actually what is associated with the systemic lupus erythematosus. All right, so the developments of autoantibodies in systemic lupus erythematosus, of course, patients will develop antibodies because of the defective B cell tolerance for self-antigen. So you remember the first discussion, the first presentation in systemic lupus, in autoimmune disorders, we discussed about immune tolerance. It was the first discussion. If you didn't attend, or if you don't remember, you can go back to our YouTube channel. That one is there on YouTube channel. Or if you cannot remember that, you can also log in on your website, your portal. You'll be able to see it as a link just next to this content. You'll be able to find the link for that lecture. Then you can be able to revise it. So immune tolerance is normally the peripheral and also the central immune tolerance. Of course, in both way of immune tolerance, B lymphocytes are checked for tolerance, of course, to tolerate. They tolerate, of course, the self-antigens. In case of the failure or defective in B cell tolerance, that can lead to the systemic lupus erythematosus, right? So both genetic and environmental factors has been also implicated in the disease, but there is no single cause of systemic lupus erythematosus. So the predisposition genetically, it is also known to occur sometimes with the families, but there's no identified gene or gene associated with the lupus. But sometimes we have been also suspecting that some genes on chromosome 6 have been associated with the disease, but it is not really a direct cause of the systemic lupus erythematosus. So other environmental factors are also associated with it, and as well as hormonal factors. For example, estrogen in women, antibiotics, and diet has also been associated with the lupus. But antibodies against the T lymphocyte, including the membrane molecules that mediate their response, are also detected in these patients. So it is like a combination of disturbance in the immune system that can lead to autoimmune disorder. It is not like a single, some immune disorders are associated with a single cause, but most of immune disorders are associated with just a combination of disturbance of the immune tolerance. Any defect in immune tolerance can lead to autoimmune disorder. Lupus can occur at any age or at any gender, but of course it is 15 times. It is up to 15 times more frequently in women than in men after puberty, of course, and the high incidence is in black women than whites. So this is of course data records in the United States, because it is not like in Africa. So when you look at, of course, in Africa, most of us are black, but in America, black women are more affected by this systemic lupus erythematosus than whites in that country. So the highest mortality rate is in patients with progressive renal involvement and also central nervous system involvement. And the most common cause of death is about renal failure and even complications of infections. So those are the most common cause of death. Okay. Signs and symptoms of the systemic lupus. Of course, the disease, it always occur in different ways. First of all, it can be acute, it can be chronic, it can have some remission periods, it can also relapse, or it can have failed or active form of the disease. So fever is the most common clinical manifestation in systemic lupus. Always, fever is the most common clinical manifestation in systemic lupus. So about antibodies, with elevated titer that are characterized by that are characteristic of systemic lupus, they can be the cause later than infections, and those antibodies will be anti-double-stranded DNA. So these are the common antibodies that are seen in systemic lupus: anti-double-stranded DNA and also anti-ribosomal P antibodies. Also complement and leukopenia reduction will also be occurring in this disease. So, but anti-double-stranded DNA is very, very high in systemic lupus erythematosus, and many of the clinical manifestations are just consequence of tissue damage because of problems like vasculopathy mediated by immune complex. So vasculopathy, for example, kidney or renal failure, or glomerulonephritis, or damage to the glomerulus of the kidneys because of immune complex deposition in the kidney. That is the major manifestation of the systemic lupus. And the manifestation of the disease can range just from typical mild illness to just limited case of photosensitivity, facial rash, as well as transient diffuse arthritis, to serious life-threatening involvement of the central nervous system and the renal and cardiac and respiratory system. So most systems are affected. So that's why systemic lupus is considered a multi-organ or multi-system condition. So the cause of disease is very variable. Sometimes it can be it usually follows a chronic phase, irregular courses with the period of exacerbations and remissions. Sometimes exacerbations, like very active form of disease, and also remission time without symptoms. So multiple organs are affected at the same time, and the clinical symptoms can include, apart from fever, weight loss, malaise, arthralgia, which is joint pain, of course, and also arthritis, which is the inflammation of joints, erythematosis, which affects of course the skin, and the micropapular, which is also called the butterfly rash over the bridge of the nose. So sometimes, like for example, this person is white, right? You can see now the butterfly rash over the bridge of the nose. So now, what is very, very important for you in systemic lupus, it is immunologic manifestations. What do you find at the level of immunology in a systemic lupus? We normally find the involvement of some cells that are involving, including B lymphocyte, T lymphocyte, dendritic cells. They are involved, and they are characterized by loss of tolerance, which means B lymphocyte can lose tolerance to self-antigens. T lymphocyte can also lose tolerance, and dendritic cells, they can also lose tolerance. And dendritic cells, they can process antigen and present it to the T lymphocytes, and the T lymphocyte is able to direct the B lymphocyte to produce specific antibodies. And you can see this is just enough to mediate the manifestations and pathogenesis of systemic lupus erythematosus. So there are also another problem apart from this involvement of cells. There is also another problem which include deposition of immune complex and also multiple organ involvement. So multiple organ involvement is also another problem. So patients with systemic lupus produce multiple autoantibodies, of course, because of polyclonal activation of B lymphocytes. So B lymphocytes are activated in a polyclonal fashion, which means there are different clonal or clones of B lymphocyte to be activated and synthesize different antibodies. And those antibodies are going to affect multiple antigens. And because of multiple antigen stimulations, that is why B cell polyclonal activation takes place, because of multiple antigen stimulations. So multiple antigen enable B lymphocytes also to synthesize multiple antibodies against those antigens. But of course, antigens are just self-antigen, most of them. So laboratory features that we expect in systemic lupus erythematosus, of course, it is antinuclear antibodies. Antinuclear antibodies is a classic finding. And you could see some questions where they ask you which autoimmune disease that we must find positive antinuclear antibodies. That is systemic lupus erythematosus. Even though in other conditions we find antinuclear antibodies, for example, like autoimmune hepatitis, for example, progressive systemic sclerosis, what you call PSS, the PSS. We also find in some percentage we also find the autoantibodies against nuclear antigens, which are of course antinuclear antibodies. But a classic disease in which we find positive antinuclear antibodies is a systemic lupus erythematosus, and plus immune complex deposition, decreased complement levels because of consumption and use, and tissue deposition of immunoglobulins, as well as deposition of complements, circulating anticoagulants, right? How do we call them? We call them lupus anticoagulants, and other autoantibodies. You know how to detect lupus anticoagulants and how to treat patients who is showing lupus anticoagulants, because lupus anticoagulants can also cause serious bleeding, hemorrhage without any other cause. So we have to someone has good levels of clotting factors, but because of lupus anticoagulants, especially those anticoagulants against some factors, for example, anti-factor 8, anti-factor 7, anti-factor 9, so those can also be there in systemic lupus erythematosus. Human antineutrophilic cytoplasmic antibody is also very common, is also detected in systemic lupus erythematosus. So you can see a number of antibodies that we detect, or a number of immunological factors that you have to screen and detect in systemic lupus. So now what happens in cellular level, apart from humoral level, which is of course antibody involvement and antigen, what is normally seen at cellular level in this condition? So at cellular level, we are able to see aberrations or abnormality. Aberrations means abnormality in T cell and B cell function, right? And among T cell subset, a lack of or reduced generalized suppressor T cell function and hyperproduction of helper T cell occur in this condition. So there is a hypersecretion, hyperproduction of helper T cell, and also reduction of suppressor T cell function. You know, T cell has to function, but in some exaggerated fashion of T cell function, it must have another suppressor protein to suppress the function of T lymphocytes. But in this case now, there is no suppressor protein that is going to suppress T lymphocytes. So patient will also exhibit spontaneous lymphocyte hyperactivity. What is hyperactivity? Of course, it is going to be hyperactive in hypersecretion of different autoantibodies. So all of this is going to cause problems to the host, that is at cellular levels. So, but in humoral aspects, that's where we are going to talk about different antibodies in humoral aspects. So, circulating immune complex is the hallmark of systemic lupus erythematosus. So that's one you have to record it somewhere. Circulating immune complex is the hallmark in systemic lupus erythematosus. So patients with systemic lupus erythematosus, they would have multiple serum antibodies which react to native or even altered self-antigen, like antibodies against, right? We are going to see the antibodies that are targeted in systemic lupus. So here we're talking about native antigens. Native antigens. So native antigens are those antigens that have not been even exposed and or involved in any immune activity or any immune function. So those are called native antigens. So sometimes even there are some antigens that are altered, like they are native, but they are modified by some circumstances. So those are called altered self-antigens. They're also targeted in this condition. So those antigens that are targeted, they are nuclear components. So we find antibody against nuclear components, and even antibodies against cell surface, antibody against cytoplasmic antigens, and also many other, for example, immunoglobulin G, antibody against immunoglobulin G. So those are antibody against other antibodies. So those antibody against immunoglobulin G. So you find that autoantibody in systemic lupus erythematosus are antibody to almost any organ or any tissue in the body. Any organ or any tissue in the body. And then you find that antibody to host antigen, especially the antibodies against DNA. Antibody to the DNA, that is what we call anti-DNA or anti-double-stranded DNA antibodies. So, of course, anti-nuclear antibody are very heterogeneous group of antibodies. You find that in systemic lupus erythematosus, antibodies are found against every antigen within the nucleus. So those are anti-nuclear antibodies. So, for example, there is antibodies there would be antibodies against DNA, antibody to the RNA, antibody to the proteins, for example, histones proteins and non-histones proteins in the nucleus. So drug-induced case of lupus have been also involved in the production of antibody against histone. So some of these antibodies are against double-stranded helical DNA. So that's what we call native DNA. So native DNA is also double-stranded. So if they write, sometimes they will write native DNA, or sometimes they write just double-stranded. So they are the same things. So because native DNA is that DNA which is helical, which has not been unfolded in order to participate in any expression, for example, transcription and yes, especially transcription in order to produce a RNA. So other nuclear antibodies, they are directed against single-stranded DNA, that one that was uncoiled in order to undergo, for example, replication and transcription to give rise to RNA. So those are all the antibodies that are detected in a systemic lupus. And also, we find other antibodies that are also very common in the systemic lupus. For example, antibody to the Smith antigen. So Smith antigen is also another antigen, of course, in the nucleus. This is a nuclear acidic protein. So it is a Smith antigen. So we find antibodies and we call it antibody to Smith or anti-Smith antibody. Of course, this is a marker for systemic lupus because anti-Smith has been found almost exclusively in patients with the systemic lupus erythematosus. So which means anti-Smith antibody is really a differential criteria in the systemic lupus and is a characteristic because it has been found almost exclusively in this condition. Another antibody that is found in systemic lupus, it is called antinuclear antibody against deoxyribonucleoprotein, which is called anti-DNP, which gives rise to the lupus cell. The lupus erythematosus cell is found in more than 80%, 90% of patients with active systemic lupus erythematosus. So it is not in 100%, but anti-deoxyribonucleoprotein antibodies, they are found in 90% of systemic lupus active forms. Also, other antibodies that are found in systemic lupus, all of them, as you can see, all of them are antinuclear because they are all found to detect or to target or to be directed against nuclear antigens. So they are called antinuclear antibodies. So antibody to the Robert, so we call them anti-Robert antibodies, and also anti-soluble substance A, those are also antibodies against the nuclear antigen. So anti-Robert, as you remember, anti-Robert are also found in what we call neonatal lupus. Neonatal lupus, you remember, we find the anti-Robert and anti-soluble substance A. So they are also found in the lupus, systemic lupus, but in the form of neonatal lupus. So antibody to the lane soluble substance B are associated with the systemic lupus with primary and secondary form of Sjogren syndrome. So remember the Sjogren syndrome. Sjogren syndrome is, of course, what you call exocrine disease, exocrine autoimmune disease, Sjogren syndrome. So when it is involved as well, you find also anti-soluble substance A and anti-soluble substance B, which is anti-lane. So they are found in a case of systemic lupus, but with involvement of Sjogren syndrome. So the presence of soluble substance A antibodies in systemic lupus indicate mild disease. So indicates that at least the patient has got a good prognosis, right? So when present as the only antibodies, soluble substance B is associated with primary Sjogren syndrome. When it is only found in systemic lupus, anti-soluble substance B it has a connection with the Sjogren syndrome, which is, of course, exocrine autoimmune disease. So apart from these antibodies against the nucleus, so we have seen all the anti-nuclear antibodies. Of course, anti-nuclear antibodies are all antibodies against any part of the nucleus or the whole nucleus. So, but also apart from that, we have also autoantibodies against RBC, so which can cause hemolytic anemias. So those ones, for example, can be detected using anti-human globulin tests. You know, those anti-human globulin tests can be able to detect antibodies that have coated RBC. So apart from that, also membrane-specific autoantibodies against neutrophil and platelet, and also autoantibodies against lymphocytes themselves, they can also be there, but they are called reactive antibodies. So that is also very specific for systemic lupus disease in which we find autoantibodies against almost every cell in the blood. It is specific for systemic lupus erythematosus. So apart from that, of course, apart from the presence of autoantibodies, that is the first thing. But the second and very important thing is consequence. What is the consequence of those antibodies? Now you are trying to talk about the autoantibodies, but what is the consequence of the presence of those autoantibodies in patients? So the problem is formation of immune complex, which is not able to be eliminated by monocytes, and the immune complex is going to accumulate in the blood. So those immune complex, when they are circulating, they will be deposited everywhere in the subendothelial layers of the vascular basement membrane, of course, under the endothelial cells, because you remember that endothelial cell is just a lining or a simple layer of cells that line lumen of the blood vessels. So under or subendothelial layers are actually affected. That's what you call basement membrane of the endothelial system. So they will be affected in multiple organs, because you remember that every organ in the body has got blood supply. Every blood supply or every network of the vasculature will be affected by the deposition of immune complex. So, and this is going to cause a problem. And which problem is going to happen is inflammation and cell-mediated tissue injury. So these are the very bad problem that's going to happen as a consequence of those all autoantibodies that we're talking about. So now, finally, what is diagnostic evaluation of the systemic lupus? Laboratory diagnostic evaluation of systemic lupus. So the findings of systemic lupus can be different. Some of them can be histologic, others can be hematologic, others can be serologic. All of them can actually be show that or reflect the multisystem nature of this condition. Now, what are some of the histologic changes that we have to expect in systemic lupus erythematosus? The earliest pathologic abnormalities, especially, it include acute vasculitis because of the vasculature deposition of immune complex. It can cause vasculitis, which is the inflammation of the blood vessels. Supportive tissue become edematous, initially infiltrated with neutrophil and later with the plasma cell and lymphocytes. So the two renal abnormality will also be seen as histologic manifestations, for example, proliferative glomerulonephritis as well as membranous nephritis. So these are the two abnormalities of the kidneys in this condition of the systemic lupus erythematosus. So hematologic and hemostatic findings, apart from histologic, in hemostasis or in the blood coagulation system or in hematologic, some of the hematologic findings, of course, include moderate anemia because of chronic disease, and lymphocytopenia is also very common. Thrombocytopenia can also be seen. Lupus anticoagulant is also another problem that can prolong PT and APTT, right? Bleeding test will be prolonged because of the lupus anticoagulant. You remember, lupus anticoagulants can be a problem, especially affecting coagulation factor 8 and 7, and many other coagulation factors also be affected depending on which lupus anticoagulants. So you find that if factor 7 is affected, PT is going to be prolonged. If factor 8 is affected, PTT is also prolonged, because remember, PTT is there to test for intrinsic factor cascade, but PT is going to test extrinsic factor cascade, in which, of course, we find factor 7. So because lupus anticoagulant is inhibitor it is inhibitor or prothrombin activator, it is found in many problems. For example, lupus anticoagulant is not only a problem in the bleeding, but it is also a problem in formation of thrombi, right? Thrombi formation. So you find that someone with lupus anticoagulant is going to experience excessive thrombosis plus episode of bleeding, right? Episode of bleeding and also thrombotic episodes, because it can be activator or inhibitor of prothrombin. So that's why you find it in both bleeding and thrombotic episode. So then you find some patients with the systemic lupus, they are experiencing thrombotic episode plus bleeding. So that is a very serious manifestation. So some autoantibodies are also found against factor 8, factor 9, factor 11, factor 13. They are also been described. So then serologic findings. In case of serology, what do you expect in serology? Of course, in case of systemic lupus, of course, we expect high levels of anti-DNA antibodies, reduce the complement levels, and also break down components or break down products of the complement system, include C3d and C3c. And also we find also monoclonal gammopathies. We find increased levels of gamma globulins, which lead to hyperviscosity syndrome and renal tubular acidosis. So hyperviscosity syndrome is, of course, a manifestation, but not a disease. It's a manifestation of monoclonal gammopathy. So monoclonal gammopathy is a condition, but hyperviscosity syndrome is just a manifestation of these increased levels of gamma globulins in the body, and even sometimes even IgM in the body can lead to the hyperviscosity syndrome of blood. So the following procedure results are going to be helpful for us: antibody to double-stranded DNA, antibody to C3C4, antibody against cryoglobuline levels. So the best lab procedure for monitoring of activity of renal disease are the serum creatinine levels, urinary protein levels, and also examination of urine sediments. So you can also find, of course, lupus cells or lupus erythematosus cells. You remember them, right? In body fluid analysis, the way we stain them, the way we examine them, and the characteristic on the microscope. So apart from that, finally, let's talk about anti-nuclear antibodies, and then later we'll come back to see how to interpret indirect immunofluorescence anti-nuclear antibody technique. That will be a separate technique to interpret. Probably I could just produce a video on that, record, even if it is on weekend. Then you can watch it without coming back to it next Monday, because we have a lot to do in immunology. So anti-nuclear antibodies are antibodies in a class of IgG, IgM, and IgA, and those antibodies have been associated with the nucleus, the whole nucleus, or the nuclear components. For example, antiproteins, anti-DNA, antihistones, and so on. So they are all autoantibodies against the nuclear components. So anti-nuclear antibodies are found in other conditions. Apart from this, systemic lupus, they are also found in other conditions, including, of course, rheumatoid arthritis. And sometimes they have been associated with some drugs. And some older adults, for example, elderly people, you find in their blood, they have some autoantibodies in their blood without disease. But that is, they are few. They are not really high titer to cause problems. Anti-nuclear antibodies are present in 95%, more than 95% of cases of systemic lupus, we find anti-nuclear antibodies. So because detection of anti-nuclear antibodies is not diagnostic for only systemic lupus, but their presence cannot confirm the disease, but the absence can rule out, right? Absence of anti-nuclear antibodies can rule out systemic lupus, but even their presence does not really confirm this condition, because we have seen many other autoimmune diseases in which we find also these anti-nuclear antibodies. So anti-nuclear antibodies can be divided into 4 groups depending on their classification in systemic lupus. Some of them are against DNA, anti-DNA. Others are against centromeres. We call them anti-centromeres antibodies. Others are against histone, which is, of course, histone in the nucleus, and antibodies against non-histone proteins, many other proteins in the nucleus, and also antibodies against nucleoli antigens. So we can classify them in these groups. So, for example, antibody against DNA, right? Those are antibody against native DNA or antibodies against single-stranded DNA. So they can be in 2 categories. Antibody against DNA, they can be against double-stranded, or they can be against single-stranded. So antibodies against native DNA, they will just appear to interact with the backbone of the helical DNA, right? And those antibodies against double-stranded DNA, they can be detected. They can stain the kinetoplast of the hemoflagellate Cryptidia rucellai, which is a substrate used to detect anti-double-stranded DNA. This is a very important thing to remember. It has been there in questions, in ASCPi questions, where you are asked to choose which substrate do we use to detect anti-double-stranded DNA. So those are this is the hemophilagerate Lucile, which is used to detect those autoantibodies. Antibodies reactive to the single-stranded DNA. There are those antibodies that are able to recognize purines and pyrimidine bases, because this is, of course, a denatured DNA. So antibody to histones are also very, very many there. Antibody against histones, as you can see, antibody to histones are those antibodies, of course, that react with the histones, proteins, histone 1 to histone 4. And those antihistone antibodies, as you remember, they are also associated with the drug-induced type of lupus. So, for example, of course, procainamides and also hydralazine. These are the drugs that can induce antihistone antibodies. So, also systemic lupus has been showing other types of antibodies. As you remember, they have been showing antibody against MYTH, anti-ribonucleoprotein, anti-double-stranded DNA, anti-chromatin, anti-soluble substance A, as of course anti-Robert antibodies. They have been all found in the systemic lupus erythematosus. So these are the 11 criteria for us to diagnose systemic lupus. You read them, all of them: rash, photosensitivity rash, ulcers, arthritis, pericarditis, renal disease, neurological conditions, hematological disease, immunological disorders, positive antinuclear antibodies. All of them are 11 criteria to diagnose or to definitively diagnose systemic lupus erythematosus. So at least if patient exhibit 4 criteria, they can, of course, use to diagnose systemic lupus erythematosus. So, antibody against nucleoproteins are also there. Those antibodies against nucleolar antigens. The antibodies are against U3 RNA protein complex, 72 RNP, RNA polymerase, PM, SCR. Those are all antibodies that are seen against nucleolar proteins. So those antibodies are primarily associated with polymyositis, scleroderma overlap. You remember this condition, which is called the polymyositis. Remember, polymyositis is a condition which affects skin and other internal organs. So it is also an autoimmune disease. So, but they are rarely demonstrated in progressive systemic sclerosis or dermatomyositis or scleroderma. So, but they are seen in polymyositis and scleroderma overlap. So those are the anti-nucleoli antibodies. So I will show you also how to interpret the nucleolar reaction when it comes to immunofluorescence antibody, immunofluorescence, indirect immunofluorescence, anti-nuclear antibody testings. All right. So let's just close our today's discussion just here, because we have also laboratory evaluation techniques of antinuclear antibodies. Especially, we will be discussing how to interpret indirect immunofluorescence antinuclear antibody technique, how they react, like fluorescence reaction, because we have to use fluorescence microscopy, and of course observe the reaction of the nuclei of the cell used, especially human epithelial cells. So we can use them to show reactions in fluorescence, right? So that technique we are going to if not to wait from until Monday, I'm going to produce a video explaining how the reaction we interpret a reaction, because it is also very, very important in exam. Very important. You will be able to see some of the pictures. They bring pictures and they will ask you to say, is this homogeneous? Is this speckled? Is this nucleolar, and so on. So thank you so much for this time, and I can now receive questions. If someone has a question, I can take the question. Otherwise, God bless you and have a blessed weekend. Thank you.